Good evening to everybody. Welcome to the IARS Virtual Education webinar titled Vasoplegia, Facts, Fable, and Future. Today is Tuesday, November 18th, 2025. I would like to welcome everybody who is participating. This program has not received any commercial support, and you will see the disclosures of the presenters during the presentations. For those who missed the 2025 annual meeting, feel free to access on-demand recordings, which are available for purchase, and you can see the link at the bottom of the slide and in the recording. And for those who wish to join us in 2026, Montreal is a beautiful city. May 1st to the 3rd, it will be the 2026 annual meeting, and would like to see as many of you as possible. There are two upcoming webinars. There is the one of December 2025 titled Unveiling the Past, Embracing the Present, Shaping the Future in Transplant Anesthesia. And the first one of 2026 in January, Breathing Easy, From Difficult Airway to Every Airway, Improving the Safety of Airway Management in Pediatric Anesthesia. There will be questions and answers. Please use the button on the Zoom taskbar, and we will answer them all in the order they are received. I am the moderator. My name is Nick Skubas. I am at the Cleveland Clinic, and I'm joined by two colleagues in principle, one very close, Dr. Zakaria, Luai Zakaria. He's an intensivist and cardiac anesthesiologist at the Cleveland Clinic with me, and from a little bit less close, but close still, Dr. Matthew Levin from Mount Sinai, New York, who will be closing the presentations, last but not least. So I decided to frame the content of my co-presenters with the background of the pacing come-and-go bypass, the post-cardiotomy shock. And that's how I would like to introduce the problem of vasoplegia, and I call it the chimera of vasoplegia. I have no disclosures and no conflicts for this presentation. Chimera is a mythical monster that is comprised of different species, two heads, two different sets of legs, different tail, different bodies. This is how sometimes I do feel when I am trying to treat blood pressure and my armamentarium is being exhausted and I don't see the result that I wish for. So we'll proceed with some classic definitions of shock. I will introduce the dynamic classification as introduced by the Society of Cardiologists and Angiography and Interventions, the SCAI, and I will frame them all with the post-cardiotomy, what we have found so far with retrospective analysis, to introduce the next two speakers. Cardiogenic shock is typically a stage D heart failure, systolic hypotension, elevated filling pressures, low stroke volume. The system cannot meet the metabolic demands. But notice here in this graph on the pressure volume loop, there's no perfusion indices. It's all hemodynamics. It is accepted, and I believe this is the case both for surgical and medical patients, that when we talk about cardiogenic shock, we talk about systolic hypotension, less than 90 millimeters of mercury for more than half an hour, or around 90 millimeters of mercury with medication. We talk about failure of the left side because the pulmonary capillary wedge pressure is more than 15. 15 is the typical normality number, although there are doubts about the value. Less than 15 empty, about 15 euvolemia, and there is some degree of hyperperfusion with any of the parameters that you can see. Urine output, the least likely that we will be following in the operating room. Lactate, more likely because of available in the blood gas. Now, these old school phenotypes of cardiogenic shock are good to contradict the pure cardiogenic shock, cardiac index is low, SVR is up, to the vasodilatory shock, pure vasodilatation, where we expect the cardiac index is good, cardiac function is fine, the SVR is low. Now here I would like to emphasize that SVR is a parameter that we do not measure. It's a parameter that is calculated, and the calculation uses the cardiac index. The wedge is not part of the calculation of the SVR, it's part of the PVR calculation. There's no hypoperfusion parameter in the typical cardiogenic shock. When we contradict the vasodilatory shock with a mixed shock, obviously the changes that we expect to see is a difference in cardiac index. In the mixed shock, the cardiac index should be low, and the SVR should not be low, should be close to normal, with elevated filling pressures, not denoting the cardiogenic part. When we contradict the mixed shock with a classic cardiogenic shock, in both cases, the index will be low. And again, the difference is in the SVR and the filling pressures. And again, I will close one more time by saying that we do take the SVR into this classification, but again, it's something that depends on the measured cardiac index. It's not an independent parameter. Enter the SCAI, Society of Cardiovascular Angiography and Intervention, whereby they present a dynamic shock staging going from left to right, from A to E. And I will present how this staging is applicable. Stage A is the hemodynamically stable patient, any patient who potentially can go into a shock. This is a patient using the post-bypass period who's stable, does not require any medication, blood pressure is fine, and perfusion is fine. Once there is either hypotension or normal blood pressure with hypoperfusion, and here conveniently lactate is the parameter, we enter stage B, where the patient is considered to be unstable, either by perfusion or for blood pressure. Stage C is the classical shock, whereby we have both hypotension and hypoperfusion. Again, the parameters, you see them on the slide: systolic blood pressure less than 90 or mean pressure between 50 and 65, and lactate more than 2 millimoles per liter without supportive medications. Stage D is the deterioration, where we have hypotension, hypoperfusion, regardless, despite the use of medication and or devices. And stage E is the stage of extremis. Imagine the open chested patient that requires ECMO or Impella to support the hemodynamics. So if we put them in a pyramid, and I like this because it is simplified, and this simplification is applicable, everybody can use it. We go from A, bottom, normal, to E, extremis, and we categorize blood pressure and perfusion, A being stable perfusion, stable blood pressure, intact perfusion, B, hypotension with normal perfusion, C, the classical stage, low blood pressure, impaired perfusion, D, the deterioration because of the need for medication devices, and E, the extremis. Now, that was fitted retrospectively in the patients, and these are medical patients. There are only 2 studies with the CICU in the cardiac intensive care unit. Some of them are surgical. And notice that regardless of the population, with this staging, all red bars, stage E, and the light gray bars, stage D, have a very high mortality. Now, we take that from the medical literature and we apply it retrospectively to the surgical population. The first study came out in 2022 from Berlin Heart Institute. Over the course of 10 years, they examined their own patients and they entered them into their study at the time that they received in the cardiac surgical ICU. So about 26,000 patients over the course of 10 years, distributed among the 5 stages of the shock. And they found out that regardless of the type of the surgery, there was everybody, all type of patients in any type of surgery will have some degree from A to E. Very high percentage of E and D are in VADS, mechanical circulatory support, and transplant surgery, as expected, because these are our sicker patients. And again, regardless whether it was a bypass on the top left, on or off pump on the bottom left, whether it was a valve, aortic surgery, TAVR, emergency or elective, the first part of the study, the second part of the study, any patient who is in stage D or E, regardless of the type of the surgery, has increased in-hospital mortality. So here on the top right, this is the same for both in-hospital as well as the cardiac ICU mortality. Notice that the D and E stages appear, D is kissing 5%, stage E is above 5%, almost 25%. But more important, the yellow arrow connects from the bottom right stage C that shows a mortality of about 30% to the top right, the stage Z. The bottom right shows the change by one stage. So regardless of what the initial stage was, if the patient advances one stage, the mortality increases. So while a patient entering the ICU at stage C has a mortality less than 5%, a patient in stage B that advanced to stage C has much worse mortality. It's a dynamic classification, very useful, easy to use, and that translates as well to the different morbidities. Using now a much broader database, here's the STS database. They examine the classification of the patients both before surgery as well as after surgery, again, using the same pyramid from A to E. And this is the distribution of the patients before the surgery, and they're about 2/3 CABGs and a little bit combined and valve. This database did not include transplants. It only included bypass, CABG valve, and valve procedures. Many patients changed shock stage from the pre on the left to the post state on the right. And again, here, increasing the stage by one from the before to the post operative period increased mortality exponentially. Here in graphical format on the right, notice that the gray bar shows the mortality when the stage was increased by one. So any patient, even if starting from at any stage, from B or even C, the light shock stages, once they advance to the next stage, things get worse. Again, associations, retrospective, big data, but again, only associations can be found. Predictors of worsening post-bypass, post-operatively were bypass time, cross-clamp time, and the pre-op stage. Things that we cannot really address a lot unless we cut the surgery time by half, etc. So where does this leave us? When I titled the presentation, my part as a Chimera is that there are too many things happening at the same time. I think it's time to go away from the classical old school type of classification of shock, of cardiovascular instability and hypoperfusion. We have to deal, there is no clear-cut line that separates cardiogenic purely, vasoplegic purely, or how much they mix. So our treatment is concurrent, and we attack the patient with vasoactive medications, with inotropes, as well as with the medication that Dr. Zakaria and Dr. Levin will present forward, because we try to not only stabilize the hemodynamics, but we emphasize with this webinar, we need to improve the perfusion. And looking forward, there is a trifecta of things that need to be dealt in the post-cardiotomy period, looking at the models that are only retrospective. So we need to look at the models and try to train these models going forward. We need to agree among us in our communities what will be the definition so our data can translate to each other. And even more important, in a disciplined and a prospective way, the scientific way, to choose the medication or medications, the dose, the timing, and to what goal should be administered for the benefit of our patients. So that was the end of my presentation. I will unshare my screen, and I will invite next Dr. Zakaria for his part. Thank you.
You can see my slides. Perfect. Hi, everyone. Thank you so much for joining our webinar. I will be discussing targeted therapies and possible pitfalls in vasodilatory shock as an extension to the conversation we've been having. I have one disclosure. I'm an investigator. I have an investigator-initiated grant from the company that manufactures hydroxycobalamin or cyanokit. We completed this retrospective study this past month, and I do not have any personal or financial disclosures to give you. So first we'll begin with a case. This is a 75-year-old man with a history of aortic valve replacement, chronic kidney disease, diabetes, hypertension, coronary artery disease, presenting with shortness of breath and found to have severe mitral regurgitation and aortic stenosis, as well as coronary artery disease. He underwent redo, CABG, AVR, MVR with a 2.5-hour cardiopulmonary bypass time. Coming off of bypass, he requires high-dose vasopressors and inotropes. To facilitate separation from cardiopulmonary bypass, he receives 2 milligrams of IV milrinone, norepinephrine at 20 mics per minute, vasopressin at 0.06 units per minute, and epinephrine at 6 mics per minute. He receives multiple blood products, as seen here, and his hemodynamics are the following. His MAP is 55, his cardiac index is normal, it's 2.5, and his SVR is low, it's 600 via Swan-Ganz catheter. His echo shows a normal biventricular function and with inotropic support. So I want you to pause and think about what you would do in this situation. What is this disease state? What would you do next in regards to the hypotension specifically? Would you administer steroids? Would you increase his pressor dose? Would you add another pressor? Would you give him vitamins? And what's the level of evidence for what you are proposing? So to continue this discussion, the first pitfall is that vasoplegia has no universal definition. Here in a recent article published in JACC, you can see that there's numerous definitions in the literature, which include hypotension, markers of volume status, use of inotropes and vasopressors, and hemodynamic thresholds. This makes making informed decisions on evidence-based decision-making and operating room very challenging, and we do a lot of extrapolation from our literature. In most studies, you see hypotension, normal heart function, and vasodilation. And in some, you may see high-dose vasopressors as a requirement for refractory vasoplegic shock. So what does that mean exactly? Here's a chart of how the literature converts vasopressors to quantifiable equivalents. So for example, in our case, patient is on these vasopressors, and if you add them all up, it amounts to 0.475 mics per kilo per minute of norepinephrine equivalents. And so it's a way for us to compare the literature and the needs of vasopressors and inotropes between patients. Vasoplegia is also, has many names in the literature. You may see low SVR syndrome, vasoplegic shock, post-cardiotomy shock. My favorites are catecholamine-resistant vasoplegia and vascular hypovasoreactivity, because I think they speak to the inherent problem we're encountering when we're dealing with this disease process. As Dr. Skubas said in his talk, vasoplegia after cardiac surgery doesn't happen in a vacuum. Oftentimes, there's concomitant myocardial dysfunction and stunning, ischemic injury after cardiopulmonary bypass, which creates a mixed shock picture. This may also be seen in sepsis with cardiomyopathy phenotypes. These elements all amount to cardiac and peripheral vascular dysfunction, which lend themselves to a mixed shock state, whereby we're often forced to be treating maladaptive vasodilation and cardiac decompensation. Second pitfall is that vasoplegia is a multifaceted disease. So to discuss treatments, we really need to understand the pathophysiology. So let's talk about the mechanism. Here is a very simplified explanation. We start at the smooth muscle surface, which contains receptors that have catecholamines, vasopressin, and angiotensin II. Normally, these compounds via cyclic AMP produce intracellular calcium, leading to smooth muscle contraction. The pathophysiology of vasoplegia is complex. Normal vascular tone is modified by these smooth muscle cells and these receptors. Normally, this intracellular calcium then binds to ATP-sensitive potassium channels and allowing this potassium to then leave the cell. This action causes the cell to become hyperpolarized and subsequently close voltage-gated calcium channels. The intracellular calcium is then taken up by the sarcoplasmic reticulum, which facilitates vasodilation. So usually there's a balance between vasodilation and vasoconstriction. But in critical illness, there's a depletion first of catecholamines and vasopressin, and also lactate, acidosis, reactive oxygen species, hypoxia all generate increases in nitric oxide. And increases in nitric oxide cause further vasodilation. There's actually up to 1,000-fold increase in nitric oxide from inducible nitric oxide synthase. This manifests as an inappropriate vasodilation and shock, and it's only exacerbated by malperfusion in cardiogenic shock that we see. Here you see that lactate, acidosis, and reactive oxygen species, like we said, increases nitric oxide synthase, and as a result, via cyclic GMP-mediated vasodilation via nitric oxide. So the three mechanisms, to summarize, are activation of inducible nitric oxide synthase, deficiency of vasopressin, and inadequate performance of the catecholamine and angiotensin II pathways. Pitfall 3 is that we'll kind of discuss the treatment modalities surrounding vasoplegic shock, and that a lot of this is extrapolated from sepsis data. Here is a reminder of what our patients look like. So what's the next move? Is it to give steroids, increase the pressor dose, another pressor, or vitamins? So you might ask yourself, if you want to increase the amount of norepinephrine the patient has, you might ask yourself, this patient must have a dose response curve. Such curves indicate that above a certain dose, additional drug will have little effect. At some point, there's a maximum dose in which you won't have any effect. And it suggests that the higher doses aren't dangerous, they're just that the receptors are fully saturated. However, a study this is a really old study in rats from the 80s, shows that norepinephrine had an increase in a linear effect up to 1.35 mics per kilo per minute, an astronomical dose of norepinephrine. Clinically, we don't seem to have a ceiling for norepinephrine use, but we all kind of have a maximum in our minds. And institutionally, I would say that's around 0.2 mics per kilo per minute, maybe even 0.3. The Surviving Sepsis Campaign recommends initiating vasopressin when norepinephrine is between 0.25 and 0.5 mics per kilo per minute. And as a commentary, I would probably use it much earlier in that stage, but and that's kind of the practice that we see here at Cleveland Clinic. The VAST trial, which is a combination vasopressor therapy trial, showed that the use of vasopressin in combination results in reduced norepinephrine equivalence when adding vasopressin. And this meta-analysis showed that norepinephrine plus vasopressin was superior in terms of mortality. There was really no difference in RRT use. Combination therapy is favored for reduced atrial fibrillation. And interestingly, higher rates of digital ischemia were found in monotherapy alone. The largest trial for angiotensin II, the ATHOS-3 trial, also argues that vasopressor requirements decrease with catecholamine-sparing agents. This study, which was published in the New England Journal of Medicine, showed that the addition of angiotensin improved the hemodynamics and a reduction in total vasopressor use over 48 hours. Of note, the study is about 300 patients or so. It wasn't powered for mortality, and the follow-up was 28 days. And in post-hoc analyses, responders to therapy had lower mortality rates. And in subsequent analyses, blood renin levels prior to therapy may help prognosticate patients. So this is a very evolving field, as we see. Steroids are basically all over the map, but generally speaking, the consensus seems to be that steroids may help with a reduction in vasopressor free days and time to reversal of shock, particularly in septic shock. So let's talk about methylene blue. Methylene blue acts on nitric oxide pathway to reduce the total amount of circulating nitric oxide. Originally, it was used to treat methemoglobinemia, and it since has become of interest in refractory shock. A recent trial, which is a positive study, demonstrated improvement in vasopressor-free days in patients with septic shock. And additionally, a meta-analysis showed improvements in hemodynamics and mortality. However, these are pooled data from sepsis. Here you see cardiac surgery, non-cardiac surgery settings. So we see improvement in hemodynamics and improvement in mortality, but obviously this is a very heterogeneous patient population. So making any extrapolations is difficult. So we'll talk about hydroxycobalamin or vitamin B12. Remember that vitamin B12 is an essential molecule for DNA synthesis and hemoglobin synthesis. It comes in various forms, but this one is interesting. Here you see the central cobalt molecule that is attached to a hydroxyl group, and it's thought that this hydroxyl group will be displaced by cyanide, carbon monoxide, and most importantly in our conversation, nitric oxide. So it was originally marketed as a treatment for cyanide poisoning, but here we see that it can increase your blood pressure and as a result has been used in refractory shock. The use is limited to small RCTs in cardiac surgery, in liver transplant, and in septic shock. As with methylene blue, generally the data suggests an improvement in hemodynamics in MAP and SVR, questionable improvements in oxygen delivery and mortality. And in our analysis, we showed that the hemodynamic effect of a 5-gram bolus was limited to 24 hours. One second. There are many questions to answer surrounding hydroxycobalamin, which include the ideal dose, the true effects on the circulation, patient-centered outcomes, including mortality and AKI. Renal dysfunction has become a real concern after some reports demonstrated oxalate nephropathy induced renal injury in patients treated with hydroxycobalamin. And the last pitfall we want to talk about is that a better MAP does not mean a better outcome. And there's no better story than the story of this nitric oxide synthase inhibitor, 546C88, which is about 10 years ago this study was published. This study showed that in patients with septic shock treated with this nonspecific nitric oxide synthase inhibitor, you saw an improvement in hemodynamics, improvement in MAP, and improvement in SVR. However, the study was stopped early due to an increased mortality and increased circulatory failure, particularly in low cardiac output and pulmonary hypertension. So just because you have a better blood pressure does not mean you are doing best by your patient. Another evolving story is with respect to vitamin C, which gained a lot of traction in this retrospective study, which showed a substantial mortality benefit. Subsequent studies have showed no mortality benefit in a prospective manner. In a large study published in the New England Journal, I believe last year, showed an increase in mortality in patients treated with vitamin C in adults with sepsis in the intensive care unit. So what we do and what we decide to do is not benign, and we need to be very thoughtful about creating evidence-based medicine to further our clinical practice. So where does that leave us? Same slide as Dr. Skubas is my conclusion as well. And that's that we should probably consider optimizing patients' blood pressure while fully appreciating cardiac output and tissue perfusion in mixed shock states. We should consider first and second line agents and understand that rescue therapies have limited data that's evolving and that we need to create real good studies to understand how these medications affect our patients and their outcomes. So just a food for thought, in this patient who is on high dose vasopressors and inotropes, what are you going to do? And are you going to pick any of these four things? And consider, am I improving the outcomes of my patients? And we need to continue to read and create studies that will further our understanding of this. Thank you so much.
Okay, I think it's my turn to take it home. Let me just share and get the screen set up. All right, can we confirm everyone can see my screen? Okay, great. So I'm going to talk about the future of vasoplegia. Some of my slides overlap a bit with what Luai just presented, so I will skip through them, and then I thought it was very interesting that Dr. Skubas started out with all of the shock states and the old cardiology definition of warm shock, wet shock, dry shock, because we'll come back to that. So I have two disclosures. I'm an advisor to a company called Extrico Health, and I founded a small company called Infuse Health, which has precisely one employee, myself. Neither are making me any money or have anything to do with vasoplegia. So what I wanted to do was talk about some of the new and in some cases old theories of vasodilatory shock that are floating around, the new exploratory treatments, which really overlaps a bit with Dr. Zakaria's talk, so I won't spend too much that. And then I think I'll try to focus more of the time on what I call improving the phenotype. And there's really two things. One is a classic approach, by which I mean a more of a rules-based approach. And one is the more modern approach of using AI or machine learning to help with inference when simple rules don't work. So the first thing I want to talk about in terms of new or old theories is this notion of the endothelial glycocalyx. So this is this sort of fuzzy, sticky layer that lines all of our vasculature, and it's made of these complex molecules. There's carbohydrates, there's proteins. Two of the prominent molecules are heparan sulfate and something called proteoglycan. And there's a notion that during injury that the glycocalyx gets denuded, and that the loss of this sort of fuzzy lining is part of what leads to capillary leakage and inflammation. So this is a study that is not that new, a couple years old, but this group led by Dr. Abu Arab asked the question of, are alterations in glycocalyx responsible for this leakage? So they did a prospective single center study. It was mostly cabbages and AVRs, and they quantified the levels of heparan sulfate and syndikin 1 on pre-op, ICU, and post-op day 1. So what they found was kind of interesting that, let me minimize this for a second, that it seemed that vasoplesic patients had lower levels of syndican before admission. It didn't really seem to change on ICU admission, and heparan sulfate was really the same. They had a rate of vasoplegia which is consistent with the literature. And oops, here's just a graphical version of this. So if you try to use the syndican level as a predictor of whether a patient would be vasoplegic, the predictive power, the so-called area under the curve, was about 0.7, which is not terrible. It's not great. It's kind of in the middle, sort of Goldilocks. Usually you want about 0.75 for something to be useful clinically as a prediction. So this is something that seems to have promise, but no one's really found out how to measure it well yet in terms of a predictive. And certainly I was talking to one of my, I think a fellow the other day, and they laughed, they joked, they said, yeah, I always thought that if I could invent glycocalyx in a bottle, that would be a great treatment for vasoplegia. But no one has yet invented this sticky stuff that you could just inject and recoat someone's blood vessels. So the next idea was some sort of other novel biomarkers to predict vasoplegia. And one is called flow-mediated dilation. So if you, again, this goes back to the idea that nitric oxide is released by blood vessels. And the idea here is that if you put a cuff on someone's arm and you squeeze their arm, when it's released, that nitric oxide is released. And this causes vasodilatation. So they thought perhaps if you use this as a measure, again, might you be able to predict who is going to be vasoplegic before they go to the operating room. So again, a small study, 28 patients. And unfortunately, they found that preoperatively, this flow-mediated vasodilatation did not differ between, and that's the before cardiac surgery group. On admission to the ICU, if you were vasoplegic, you had more dilatation, but that sort of makes sense. And then this idea of a response that, how reactive are your vessels or how much did you vasodilate was also greater in vasoplegic patients. Again, the problem is that if it doesn't manifest itself before you go to the OR, then it doesn't really help you to identify the patients that you want to treat prophylactically. So now this is shifting a little bit, but there's also some people who have done work again on novel biomarkers to predict vasoplegia. And the most interesting one that I saw recently was from 2022, was basically looking at indices of inflammation. And so this was a relatively large study, 1,000 patients. It did have a lot of exclusions, which I won't go through here. It used a classical definition of vasoplegia, and they looked at these ratios, so platelets times neutrophils via lymphocytes, platelets by monocytes by neutrophils divided by lymphocytes. And then they said, how well does this predict? So they found that this actually was a highly predictive marker for vasoplegia. So if you're starting out, again, this is preoperative labs. So this is preoperative. So if you're starting out in a pro-inflammatory state, the likelihood that you end up vasoplegia is much higher. And this was a 10% increase per whatever unit of change they had defined in these index. And they had good sensitivity and specificity, and they were pretty well, again, the correlation with the vasoactive inotropic score, which is one of these scores, again, like was presented where, you have a norepinephrine equivalent type of score, was reasonably good. So this is interesting, and it hasn't been further developed into anything. Now, I want you to remember briefly the microcirculation. So remember that shock or vasodilatory shock is we treat it on a macro level, but really shock happens, and shock defined as a lack of end organ perfusion happens at the microcirculatory level, where blood vessels, the bottom picture is a picture through dark field of microscopy of what the capillary circulation looks like in shock. And you see all the vessels are constricted and clogged and sludged with cells, with red cells. And that's really what shock is. So the big question always is, are we just treating the macrocirculation and not treating the microcirculation? And keep that in mind, because when we talk briefly about exploratory treatments. So, Dr. Zakaria talked about these, so I won't really go about this. I'll just point out that he's contributed recently, as he noted, to the literature about B12. A lot of case reports coming out of the various places throughout the years, going about 10 years. This was a propensity study. Again, I don't want to spend too much time on it. Most of these studies have shown no difference in these novel treatments on outcomes. They do seem to be vasopressor sparing, but they don't seem to affect outcome. This was something by Kandikar, again, very similar. And then this was the most recent study, which just came out in British Journal, trying to look at norepinephrine equivalents at 1, 4, 24, 48 hours, and then the secondary outcomes. And again, showing that it's sparing, but it unfortunately doesn't seem to decrease what you really want, which is the poor outcomes. Now, what's interesting is that there's been several attempts at more prospective tile studies, and they seem to all have not made it through. So this was terminated by insufficient recruitment, may have been affected by COVID. This was really pre-COVID, but they lost their funding. This was methylene blue versus hydroxycobalamin. This one is completed. So this is methylene blue versus cyanokit in liver transplant, and they haven't published a manuscript yet, so they're probably still in analysis. But the results, if you look on clinicaltrials.gov, seem to suggest no difference. And vitamin C, I don't want to, again, say too much about. Vitamin C is a product of Linus Pauling. He was a big proponent of it. This was a study out of Mayo. There's a bunch of other studies. The most interesting one that came out, just published, also from Mayo, and they tried to actually look, does vitamin C improve your microcirculatory circulation? And they very ambitiously tried to actually, in the OR, put this microscope in the mouth of patients to look and quantify. And they had a lot of problems with this, some of which were driven by COVID terminating recruitment. During the pandemic, you couldn't really justify doing some sort of study that involved having the patient's respiratory secretions exposed. They had a lot of issues with trying to actually put this bulky microscope in the mouth to look at it. So unfortunately, ultimately, they couldn't come to a conclusion. So whether this will ever be repeated is unclear because it sounded like they had so many technical and logistical problems. So I'll stop that, and I want to go to improving the phenotype, and I'll try and go as fast as I can so we have time left, and I apologize. But the first one, and the one that caught my eye a couple years ago, came out in 2021. It's from France. And the idea was, can we quantify vasoplegia better than just saying, well, you know it when you see it, and it's, at one point in time, if the cardiac output is high, but the SVR is low, then that's it, or, just the norepinephrine equivalence. Can we get better than that? And so what they tried to do is take the definitions that exist, but then extend them to, add the element of time. So say you're not vasoplegic if you just have one measurement that's aberrantly low. You really have to have some duration of time that you spend in this shock state to meet a definition. And so they created many combinations. So they defined minor vasoplegia as, SVR less than 800 and NORPE equivalence greater than 0.1. Major, they said, well, that's really SVR less than 700, cardiac index even higher, taking 2.5, and really much higher doses of norepi. And then they created this kind of matrix of any versus all, and more than 15, less than 15. And their primary outcome was just, how many people were vasoplegic if you look at this definition. And secondarily were the standard sort of more hard outcomes: time to extubation, time to intensive care, non-favorable discharge. So what they found was, out of the 85 patients, 60, so about 2/3 met this minor definition for in at least one axes for at least 15 minutes. 14, so 14 over 85, about 20% or 15%, met the definition of all of the criteria for at least 15 minutes. If you extended it to 30-minute period, the numbers halved, but still a decent number of people met at least one of the criteria for 30 minutes. And then they mapped this, and these are these forest plots of, what on the left side, what criteria did you meet? And on the right side, the sort of harder endpoints. What they found was really, aside from major ICU keeping you in the major any keeping in the ICU, a lot of them were very wide. And this always probably goes back to a matter of power and low number of outcomes. This is a similar slide, and again shows that major any is driving, time in the hospital, and major all is really driving time in the hospital. So I thought this was very interesting because their conclusion was that, just 15 minutes of minor vasoplegia is associated with worsening clinical outcomes. And this is analogous to a lot of the literature that came out of the Cleveland Clinic from Dan Sessler and others about, how much hypotension in the general OR is too much hypotension. And the answer is really not very much. 5 minutes less than a MAP of 65 or 60 seems to be associated with poor outcomes. So just as in the general surgical population, in the cardiac population, this it might seem that just 15 minutes is benign, but it actually seems to not be. So now I want to talk about improving the phenotype. And again, there's a lot to get through here, so I'm going as fast as I can. But this is where we start to talk about AI and ML. And this is some stuff that I've done recently with the help of a really phenomenal medical student. And we just presented this at both the ASA for one of the approaches, and also at the American Heart Association scientific session. So this is going to come out soon, but you may see it in abstract form. And so the first was, can you identify vasoplegia without a PA catheter? So the definition, the classic definition, requires a Swan-Ganz or PA catheter. However, in modern practice, for example, at our institution, only about 25 to 30% of patients actually get a Swan or a PA catheter. So can you build a model that doesn't need a PA catheter and use it to identify vasoplegia? And secondarily, can you estimate the burden on patients of vasoplegia as per the definition proposed by Swan? And this is a different Swan than the original Swan. So we did a single center retrospect study at Mount Sinai, and so it was, over 11,000 patients. And what we took measures that are available commonly in the ICU, but are not measures that need a Swan. So BSA heart rate, diastolic blood pressure, the pulse pressure, which is the difference between systolic and diastolic, and the CVP. As a ground truth, we used the classic definition of vasoplegia. And then what we did is we trained 3 different models, and then we did an ensemble model. So the first model predicted a low SVR and a high cardiac index. The second model just predicted a low SVR, and the third model just predicted a high cardiac index. And so on the right, you kind of see the flow chart. So you take how we approach the study in terms of, we had 3,300 cases with PA catheters. We took their non-invasive measurements. We created 3 models. We built the ensemble model, and we predicted the ground truth. And what we found is that on a test set, a holdout test set, you can pretty accurately predict vasoplegia even without classical SWAN data. So this is pretty interesting. So even though there was what's called a class imbalance, where we had relatively few outcomes versus non-outcomes, the AUROC was very, very high, and the AUPRC, which is a measure of precision recall, which is essentially a map of sensitivity, so false negatives against positive predictive value, was pretty good. And so at a positive predictive value of 46%, which means almost 1 in 2 patients that this ensemble model flagged as positive actually were positive, that you have very good sensitivity. So this is exciting because this says maybe we don't need a SWAN. Maybe there's ways that we can cleverly use non-invasive, I call it non-invasive when invasive means a PA catheter. And then again, we mapped this to the continuous vasoplegia burden, and we found that it matched very well to just some of the standard, map less than 60. So if you just simply said, the map was less than 60, how many patients also were vasoplegic? And you see that at any given time point, a large chunk of the patients were predicted to be vasoplegic. So this is very interesting work, and was step 1 of what we did. Then we kind of pivoted in a different direction, and we said, well, there's some problems with the conventional definition, which is this map less than 60, index greater than 2.2, and a low SVR. It fails to account for hemodynamic interdependence. So as Dr. Skubas pointed out at the very beginning of this talk, SVR is not a measured, it's a calculated parameter. But the classic simplification is that MOT minus CVP equals cardiac output times SVR. So you can have states of relatively inadequate SVR for a given cardiac output. Then there's this notion of compensated states. And so again, if you go back to the beginning of this talk, and that there's compensated shock, decompensated shock, you can be warm and wet, warm and dry, cold and wet, cold and dry. And that's from the cardiologists who have been thinking about this for 40 years. That's the first thing they think of when the patient is in the emergency room. Is this patient fluid overloaded and in shock? Is this patient dry and in shock? Where are they? And so, there's compensated states, and there's, again, relative vasoplegia. And then there's the idea of end organ perfusion. And so really end organ perfusion is perfusion pressure. And none of these are accounted for by this classic simple ruse base. And finally, there's the idea that your BSA confounds with your SVR. And I mean, for those of you who practice in the cardiac OR and you look at when patients are placed on cardiopulmonary bypass, you can think of this too. Not everybody, SVR and BSA are inversely related, and fat tissue has a different vascular resistance than muscular tissue. So to simply use SVR without considering what is this person's BSA and what is their body habitus like may create systematic bias. So we came up with a new phenotype, which we are calling resistance flow ratio, which is the ratio of SVRI to cardiac index. And this seems like almost a tautology, because you'll say, well, wait a second, SVRI, by definition includes cardiac index, and how is this possible? But it actually works quite well to let you kind of create a map, which is very similar to that old cardiology idea of warm and wet, or cold and dry, or cold and wet. And then when you use perfusion pressure to decide, well, are you compensated for this state? So we took that same set of 11,000 patients, and on the left here, you see, or on my left at least, we graphed them. So you have cardiac index versus SVRI, and you see this distribution. And then you can put lines on this distribution. So you can put one line, which is perfusion pressure, and so that's MAP minus CVP. And then you can say to yourself, well, how much do I have to increase my SVR versus my cardiac index to move my perfusion pressure up by 10 points to what would conventionally be considered an adequate perfusion pressure of 50. And what we found is that you can create kind of these 3 buckets, or you can slice this graph into 3 states. where the RFR is greater than 900, increasing your SVRI gets you to a greater increase in your perfusion, gets you to perfusion, or rather, the increase in perfusion pressure can be driven more by increasing your SVR than by cardiac output. Conversely, when your RFR is low, increasing your cardiac index, your cardiac output, is going to get you to perfusion pressure more than, or more people into that line than the increasing your SVRI. So we sort of said that this is, low cardiac output is the culprit versus low vascular tone. And we just somewhat arbitrarily said, this is, if it's 1.5 easier to restore perfusion, then that's the where you should go. The middle is the interesting bucket, which is this mixed states. And so here's a graph, or sort of, this is a grid, sort of like a Jeopardy grid, or of, these states and interpretation. And so you have on the left side your three sort of cutoffs for the resistance flow ratio. And then you can create this grid of compensated or decompensated. And you can say, what am I supposed to do? And so if your RFR is high, then likely cardiac output is going to be more efficient. But again, what state are you in? Compensated or decompensated heart failure? If your RFR is low, vasoconstriction is likely more to increase your perfusion pressure. And again, you have to say, are you compensated or decompensated? And so now we look at this, go back to this graph, and we can say that anything above pulse pressure of 50 is compensated, anything below is decompensated. And we can start to decide how we might treat people. And we can compare this kind of threefold, trifurcated graph to the conventional definitions and see what we miss. So here's sort of mapping the states. So this is your normal state. This is the decompensated mix. This is decompensated vasoplegia. There's an interesting state of compensated vasoplegia where you are vasodilated, but your cardiac index is high enough that you manage to maintain a perfusion pressure. And what you can see here in the blue is these are the patients who are missed by the conventional definition. So it's possible that using a definition like this, which again goes all the way back to the way the cardiologists think about their patients, actually will help us catch more patients and initiate early treatment. So in conclusion, this model we think is a new, yet I would say old model. It resolves a number of the limitations that might exist with the conventional definition. It may help us identify vasoplegia risk early and find those people in the bucket of decompensated vasoplegia, or possibly even in compensated vasoplegia. And so it really warrants some, prospective validation, which I hope to do myself and with my colleagues. And what I didn't put on here is that, again, the conclusion is that there are new ways that we can look at this old problem. We can change the definition. We can find definitions that don't rely on invasive swan technology or catheters. But also, when we do have those catheters, we can take advantage of the wealth of data that we have and the computing power that we have and all these fancy models to really, I think, drive forward a new era in recognition and then hopefully in treatment of vasoplegia. So that's all I have. Thank you very much. And I think we left a few minutes for questions. I'm sorry if it's not enough.
So we have some questions in the chat. We can tackle together if you guys would like. One person asks, what's your local guide at Cleveland Clinic for treatment of vasoplegic shock? This is a great question that, I think we still are developing the answer to. We are a very heavy Swan-Ganz catheter institution. But as you know, your Swan is only as good as how you use it. And that we are developing protocols for specific checks, when you're going to use it and what are you going to do when you use it, so that we standardize how we use the Swan-Ganz catheter. The question, I think, kind of lends itself, lends itself to what's your threshold to initiate various therapies, including vasopressin and hydroxycobalamin or methylene blue. And it's provider dependent here. We don't not use weight-based dosing for norepinephrine, which really irks me. But usually our literature shows, or our retrospective data shows that people start to do things differently at 0.2 mics per kilo per minute of norepinephrine, i.e. adding vasopressin. And then at 0.3 or 0.4 is when hydroxycobalamin will be used, or methylene blue. We do not have angiotensin II on formulary here. So some of my colleagues else at other institutions have told me that they've started to use angiotensin II at much, much lower doses.
I can quickly speak about Sinai. So fortunately, blessedly, we do weight-based dosing in our cardiac ICUs. We recently, about 2 years ago now, we got the other ICUs to do it. So that's nice. We, generally we just start vasopressin very early. I mean, it's almost like a first-line drug for us routinely. For the other agents, we used to use a lot of methylene blue. Then, they joke about the surgeons. The surgeon's memory is only as good as their last case. So maybe 1 or 2 patients had weird reactions. So then we pivoted to people really liking hydroxycobalamin. So we'll reach for that. We do have AT3 on formulary in a heavily restricted fashion. They're a little bit more lenient for us in the OR. None of us have actually used it in the OR yet. For the ICU, they really want you to have documented failure of other therapies before they will let you use it. With the greatest concern being, there was this higher incidence of stroke with Athos, but they're very concerned about. The other thing I think with our treatment of vasoplegia is, and this applies more to the transplant patients, which are always this difficult mixed picture, but much more of a willingness to use mechanical circulatory support and to very early do that. I always say with vasoplegia that we always also try to optimize just all the other things. So, make sure that you're not coagulopathic, make sure that the patient is warm, and do all these other things that are important for maintaining perfusion of the body. When someone's coagulopathic and bleeding, I mean, it just doubles down your problem. There was a question that I think was sort of for me, for the phenotype of vasoplegia, to avoid, if improving medical therapy to avoid the 15 minutes will improve outcome, or is the underlying process leading vasoplegia driving poor outcome? So, it's a little bit of a chicken and egg question to me, that as we saw with some of these inflammatory markers, if patients who become vasoplegic have a predisposition to this vasodilatory inflammatory shock that we could treat, it seems like maybe they do, but we still haven't been able to figure it out what it is. But we do know that once you enter this state, that it's very bad. That being in this vasodilated, leaky state is probably driving the outcome. So I don't know if that answers the question, but that's my thinking about it. I thought there was one other question. Oh, can vasoplegia be called cardioplegia? So I don't think so. I don't know if Nick would disagree. I mean, cardioplegia to me very specifically refers to what happens when you give high potassium to the heart. I mean, you'll see when you give someone high potassium cardioplegia that they get the whole body gets vasodilated. And that's because, there is believed to be some role for the potassium channels in this, because of the effect that, potassium channels have on the influx of calcium and all this kind of stuff. So that's my answer to that.
If I may jump in, and looking at questions too, yes, cardioplegia, I think it's a benevolent term. We need it to protect the heart, so we cannot call it the combination cardioplegia one. Looking at the slew of questions coming in, phenylephrine, if vasoplegia can be corrected with phenylephrine will probably going to stage B will be fine. I think what we presented here is the patient whose stage is going from stage C to D, that he's refractory to treatment, and this is where we throw everything that we have, and you saw the different medications, the different choices. One question that I have now, since I unmute myself, is to I know what we do at the Cleveland Clinic. We usually go with methylene blue because it's cheaper, and we found cyanokit being more detrimental.
Yeah.
But do you agree, Matt, with this? I mean, is your
Well, cyanokit is very expensive, yes. They were limiting it for a while also because of, it was supposed to be really for the people for cyanide poisoning in the ER, so that was an issue sometimes. And then somehow, even though they make such a fuss about money, at our place, as I'm sure they do at you, somehow we're still in the cyanokit. That's what we're going to, versus the methylene blue. But yes, it is super expensive. We know that. And the angiotensin too is also extremely expensive. So that's something where they really want to watch it.
So looking at, I recognize one of the elders of anesthesiology in general, Dr. Hessel. Thank you for joining us, Dr. Hessel. So septic vasoplegia to post-cariotomy vasoplegia, I think the septic vasoplegia is pure vasoplegia to my eyes. It's a medical patient who has an infection, is really vasoplegic. Most often the post-cariotomy states, I don't think if any measurement means anything. You're fighting a low blood pressure, and this is, I think, the situation we are addressing today. No, I would not equate it. It would have been very easy to have just pure septic shock with an intact cardiac function. We do have the TE. I noticed somebody says, do we use SWAN? Yes, we do SWAN. We do use SWAN because there's a value into feeling pressures and everything else. You see the changes in front of your eyes. I cannot, from my perspective, and Dr. Zakaria is next to me, will not throw away the Swan-Ganz catheter just because I cannot.
Agree 100%. I use the Swan in probably 30% of the patients, but it's not 100%. So that's the.
So to Dr. Levin, because again, I mean, then both first to Dr. Zakaria and then Dr. Levin, in this order, what will be the first parameter that you monitor for perfusion adequacy or not? Luai first and then Matthew.
For what, I'm sorry?
For perfusion, what will be the first intraoperatively post-bypass? What is the parameter that you will continue monitoring and trying to correct as a sign of hypoperfusion?
I mean, for me, it's you got to integrate everything because there are yeah, I know you can't pick one. That's crazy talk here.
I'll pick one.
You got the Swan, you got the T, you got the VTI, you have lactate urine output and signs of end organ dysfunction. I mean, there's the list goes on and on.
Okay, Matt.
I would say in my practice probably urine output. When I see the drop off in urine output, that is probably the first thing that I wonder about and worry about.
So to ratchet this question, make it a little bit more complicated. So you chose your parameter, and in this mixed environment, you have a cardiac index of 2.5. You're content. Now, with this index of 2.5, if your chosen perfusion index parameter is still not optimal, what do? Do you continue treating, or you say, I'm going to stop and everything will take care of itself? Matt first and then Luai.
That's an interesting question. So now it's funny because if the urine output's low, I mean, I may consider giving, so if the treatment doesn't work, so are you saying a treatment for the vasoplegia, for the what we think is the systemic vasodilatation?
Yes.
I don't think you ever stop treating. I think I would continue to escalate, and I think you have to start to get creative of, again, does this patient need a balloon pump? So are we actually in a mixed state where despite having a high cardiac index, we actually are failing to deliver adequate cardiac output to what is a extremely dilated vascular bed? And so that's where I would go. It's sort of a cheat to say, well, I would give some Lasix to improve urine output, but rarely I think I do that. But the other thing I go to, which people in the past have gotten upset when I said this, is I always look at, what's their hematocrit? What's their actual oxygen delivery? So this goes back to delay, like get a mixed venous, understand, and we I don't know about you, but we use the brain sats, and it's not a bad proxy sometimes for whether you're getting enough oxygen delivery to the body.
There is a most recent question. Allow me to interrupt you here and jump to the next one. And I will go with Matt first and then why. Question is, whether in the liver transplant patient, would the cyanokit be the first option than methylene blue?
I don't do liver transplants, so I can't speak intelligently to this. I'm sorry.
There's a recent study in that was published in Anesthesia and Analgesia. I'll refer you to that study about it's probably the most substantive um, data surrounding hydroxycobalamin in liver transplant patients. And I'm literally have to Google it as we're talking because I got to remind myself. But this was very, very recent literature that just came out. So I would point you in that direction.
So I think I heard from Luai, and I know here by about 10 to 12 mics per minute, which is not, we don't go by mics per kilo per minute, which is much less than 0.25 mics per kilo per minute, which we escalate from norepinephrine to vasopressin, if that can address. But Matt, do you go up to 20 mics per minute of norepinephrine before you switch, or you
No, I mean we do per weight-based dosing. So I think in the cardiac ICUs, more than about 0.25 mics per kilo per minute of vasopressin, people are very uncomfortable. And then because you're just so much worried about mesenteric ischemia and digit ischemia. And so at that point, you are thinking of adding ECMO, adding something that lets you come off of those doses. Our liver patients, they'll go up to, I think they go up to 0.5, and I think in our general SICU they'll even go higher than that, which to me is not the way we practice. In the cardiac ICUs, 0.25 mics per kilo per minute is usually kind of the max dose that we are comfortable with.
And as we talked about in the dynamic shock states, I think trajectory matters in this situation, and particularly in the ICU. So, if I'm seeing signs of end organ dysfunction that are worsening despite therapy, then it's time to make a big move and big change. So, whatever it is, MCS or more diagnostics, i.e. TE in the ICU, or even the initiation of some of these refractory medications.
So we're getting close to the hard stop at about 5:10. I know the recording is there together with the answers to the questions. I think if I may just be the first one, and then Luai and Matt close up with a closing sentence. To me, working for this webinar made me think twice or three times, what do I do post-bypass in my unstable patient? Obviously, they need to choose a target that you can work on and stick to this target that everybody agrees with is important. And second comment for me is that I heard from Matt before about oxygen delivery. I think we should go a little bit more deeper to what we have been used to be doing all these years and address the issue of tissue perfusion in a different way. So just the normal cardiac index with a heart rate of 100 is different than if the heart rate is 50, and we can all these mathematics, but that's the easy solution. We need to look at the perfusion, look at your blood gases, and see what else can be done for your patient. Luai next, and last but not least, Matthew. And my thanks to everybody for linking together.
I mean, I'm just incredibly excited about all these questions and the participation that came with this webinar. It's really exciting that this field is evolving and growing, and we are a part of the solution going forward. And that's what excites me about this. That we can create the definitions, we can create the protocols to standardize things, and that's what's going to be exciting in the years to come.
I would echo the words of both of my colleagues that after quite some time, I think of a relative stasis in the field, trying to look at this question, I think there's some exciting work that's going on again. And it's in both the dimensions of, trying the early identification with biomarkers and improving the definitions so that we have a better sense of when we're in mixed states. And then I really liked what Dr. Skubas said about, I agree. We have to. It's really ultimately about oxygen delivery at the tissue level and the microcirculation. So we probably have to drive towards that and incorporate some of those things, whether it's DO2 or others, into our definitions. But it's a fun time to be looking at vasoplegia again. That's for sure.
Couple of questions came from Dr. Carreras. I mean, hemoglobin, again, it's institutional memory and practice. At what level do you perfuse, do you transfuse, age, etc.? This is all temperamental. And I do not know anything about viscosity. As the last question, Matt, if you would like to address.
Well, I mean, I think you're just referring to the fact that you know, pressure of a fluid is a function of the viscosity of the fluid. And I always teach the fellows this, that, you know, if your grid is 18, your blood is thin and watery, you're just not going to have as much of a pressure head as you do when your crit is 36. I mean, that's just a fundamental of physics of fluids. So I do think there's something to it, which is why in the past I had talked about, you know, targeting a higher hemoglobin, but no one's ever really kind of looked at that. But to me, it makes a lot of intuitive sense, just that, you know, thin, watery blood, is not going to perfuse. Now, the flip side is that thick, viscous blood may sludge. So hard to say what to do.
Well, again, one more time, thank you to Luai and Matt for the trove of new knowledge and enticing things that we need to look in the future, as well as all the IARS support people, Andrea, Christine, and Tracy for helping us in this webinar. And of course, most important, all those who linked today. And thank you again for being part of this great activity. My best good night. Happy Thanksgiving to your families and all the best.
As well.
Thank you so much.
Thank you.